Hi and welcome to the lecture on soft tissue injuries. After you complete this chapter and related coursework, you will have an understanding of the types of open and closed soft tissue injuries, how to care for these injuries. This includes the use of dressings and bandages, assessment and care of different types of burns, including thermal, chemical, and electrical burns. We've talked about the Trauma National EMS Education Standard competencies previously. The student will apply fundamental knowledge to provide basic emergency care and transportation based on your assessment findings for an acutely injured patient. Soft tissue trauma, you will recognize and manage wounds, burns, both electrical, chemical, and thermal, chemicals in the eye and on the skin, pathophysiology assessment and management of wounds, including avulsions, bite wounds, lacerations, punctures, and incisions, and burns, including electrical, chemical, thermal, and radiation, as well as crush syndrome. Soft tissue injuries are common in the pre-hospital setting. They can be as simple as a cut or scrape, and they can be as serious as a life-threatening internal injury. Do not be distracted by dramatic open wounds, and do not make the mistake of neglecting other life-threatening conditions such as an obstructed airway. The soft tissues of the body can be injured through a variety of mechanisms. These include things like blunt injuries, and that occurs when the energy exchange between the patient and an object is more than the tissues can tolerate. Penetrating injuries occur when an object breaks through the skin and enters the body. Barotrauma injuries occur from sudden or extreme changes in air pressure, and burns may also result in soft tissue injury. Soft tissue trauma is the leading form of injury, and open wounds account for approximately 6.5 million emergency department visits annually, and nearly 5 million patients present with contusions or bruises. Death is often related to hemorrhage or infection, and we know that uncontrolled hemorrhage can lead to shock and death. When the skin barrier is breached, invading pathogens can cause local or systemic infection, and our goal is education because EMTs can teach children and others preventative actions. The skin is our first line of defense against external forces and infections. It is the largest organ in the body, and it is relatively tough but still susceptible to injury. The injuries can range from simple bruises and abrasions to serious lacerations and amputations. Injuries may expose blood vessels, nerves, and bones. In all instances, you must control bleeding, prevent further contamination to decrease the risk of infection, protect wounds from further damage, and apply dressings and bandages to various parts of the body. The skin varies in thickness depending on the person's age and the skin's location. It's thinner in the very young and the very old, and it's thinner on the eyelids and the lips and the ears than it is on the scalp, the back, and the soles of the feet. Thin skin is more easily damaged than thick skin. The skin has two principal layers, the epidermis and the dermis. The epidermis is the tough external layer that forms a watertight covering for the body, and the epidermis itself is composed of several layers. The dermis is the inner layer of skin. It contains the hair follicles, the sweat glands, and sebaceous glands, and blood vessels in the dermis provide the skin with nutrients and oxygen. Skin covers all the external surfaces of the body. The various openings in the body are lined with mucous membranes. Mucous membranes provide a protective barrier against a bacterial infection, and these secrete a watery substance that lubricates the openings. Mucous membranes are moist whereas the skin is dry. The skin serves many functions. It keeps out pathogens, it keeps water in, and it assists in temperature regulation. The nerves in the skin report to the brain on the environment and many sensations. So let's watch this animation again. As the body temperature drops and the temperature drops outside, the patient begins to shiver, which helps to generate heat. Any break in the skin allows bacteria to enter and raises the possibility of infection, fluid loss, and loss of thermal control. Any one of these problems can cause serious illness and even death. Pathophysiology. There are three types of soft tissue injuries: closed injuries, where damage occurs beneath the skin or the mucous membranes, and the surface of the skin remains intact. Open injuries, where there is a break in the surface of the skin or mucous membrane, and it exposes deeper tissues to contamination. And burns. Damage results from thermal heat, frictional heat, chemicals, electricity, and nuclear radiation. The pathophysiology of closed and open injuries tells us that the healing of wounds is a natural process and it involves several overlapping stages. These are all directed toward the larger goal of maintaining homeostasis. Cessation of bleeding is the primary concern, because we know that a loss of blood hinders the provision of vital nutrients and oxygen to the affected area. It also impairs the tissue's ability to eliminate wastes. The end result is abnormal or absent function, which interferes with homeostasis. The next wound healing stage is inflammation. Additional cells move into the damaged area to begin repair, and white blood cells migrate to the area to combat pathogens that have invaded exposed tissue. Lymphocytes destroy bacteria and other pathogens, and mast cells release histamine. Inflammation ultimately leads to the removal of foreign material, to damaged cellular parts, and to invading microorganisms. To replace the area damaged in a soft tissue injury, a new layer of cells must be moved into the region. Cells quickly multiply and redevelop across the edges of the wound, and except in cases of clean incisions, the appearance of the restructured area seldom returns to the pre-injury state. Despite the changed appearance, the function of the area may be restored to near normal. New blood vessels form as the body attempts to bring oxygen and nutrients to the injured tissue. New capillaries bud from intact capillaries that lie adjacent to the damaged skin. These vessels provide a conduit for oxygen and nutrients and serve as a pathway for waste removal. In the last stage of wound healing, collagen provides stability to the damaged tissue and joins wound borders, thereby closing the opened wound. Collagen is a tough, fibrous protein found in scar tissue, hair, bones, and connective tissue. Unfortunately, collagen cannot restore the damaged tissue to its original strength. Pathophysiology specifically related to burns. Burns are diffuse soft tissue injuries created by destructive energy transfer via radiation, thermal, or electrical energy. Thermal burns can occur when skin is exposed to temperatures higher than 111 degrees Fahrenheit. The severity of the thermal injury correlates directly with temperature, concentration, amount of heat energy possessed by the object or substance, and the duration of the exposure. The greater the heat energy, the deeper the wound. Exposure time is another important factor. People reflexively limit heat energy and exposure time. If clothing is on fire, or the person is trapped or unconscious, exposure time will be longer. Closed injuries. Closed soft tissue injuries are characterized by a history of blunt trauma, pain at the site of the injury, swelling beneath the skin, and discoloration. A contusion or bruise is an injury that causes bleeding beneath the skin but does not break the skin. Contusions result from blunt forces striking the body. The epidermis remains intact, but cells within the dermis are damaged and small blood vessels are usually torn. The buildup of blood produces a characteristic blue or black discoloration called ecchymosis. A hematoma is blood that is collected within damaged tissue or in a body cavity, and it occurs whenever a large blood vessel is damaged and bleeds very rapidly. It is usually associated with extensive tissue damage. A crushing injury occurs when a great amount of force is applied to the body. The extent of the damage depends on how much force is applied and the amount of time that the force is applied. Continued compression of the soft tissues will cut off circulation, producing further tissue destruction. When an area of the body is trapped for longer than 4 hours and arterial blood flow is compromised, crush syndrome can develop. Crush syndrome is significant metabolic derangement that can lead to renal failure and death. Compartment syndrome results from the swelling that occurs whenever tissues are injured. The cells that are injured leak watery fluid into the spaces between the cells. The pressure of the fluid may become great enough to compress the tissue and cause further damage, and the hallmark sign is pain out of proportion to the injury. Severe closed injuries can also damage internal organs. The greater the amount of energy absorbed from the blunt force, the greater the risk of injury to deeper structures, and you must assess all patients with closed injuries to look for more serious hidden injuries. Open injuries. Open injuries differ from closed injuries in that the protective layer of the skin is damaged, and this can produce extensive bleeding. A break in the protective skin layer or mucous membrane means that the wound is contaminated and may become infected. Contamination describes the presence of infectious organisms or foreign bodies, such as dirt, gravel, or metal, into the wound. You must address excessive bleeding and contamination in your treatment of open soft tissue wounds. and there are 4 types: abrasions, lacerations, avulsions, and penetrating wounds. An abrasion is a wound of the superficial layer of the skin, and it's caused by friction. This happens when a body part rubs or scrapes across a rough or hard surface. An abrasion usually does not penetrate completely through the dermis, but blood may ooze from the injured capillaries in the dermis. Some of the examples are road rash, road burns, strawberries, or rug burns. A laceration is a jagged cut caused by a sharp object or blunt force that shears the tissue. An incision is a sharp, smooth cut, generally caused by an instrument. The depth of the injury can vary. Lacerations and incisions may appear linear or regular or stellate or irregular. Lacerations or incisions that involve arteries or large veins may result in severe bleeding. An avulsion separates various layers of soft tissue, usually between the subcutaneous layer and the fascia, so that they become either completely detached or hang as a flap. Often there is significant bleeding, and you never remove an avulsion skin flap regardless of its size. An amputation is an injury in which part of the body is completely severed, and you can easily control the bleeding from some amputations, such as the fingers, with direct pressure and pressure dressings. If there is massive bleeding, you will need to treat the patient for hypovolemic shock. A penetrating wound is an injury resulting from a sharp-pointed object, such as a knife, an ice pick, a splinter, or a bullet. These objects can damage structures deep within the body and cause unseen bleeding. If the wound is to the chest or abdomen, the injury can cause rapid fatal bleeding. Stabbings and shootings often result in multiple penetrating injuries. You need to assess your patient carefully and identify all wounds, and count the number of penetrating injuries, especially with gunshots. Leave the distinction between entrance and exit to a physician. In a shooting, determine the type of gun and rounds fired and document your care. You may have to testify in court. Blast injuries also may often result in multiple penetrating injuries. You have your primary blast injury, which is damage caused by pressure of the explosion, and you have secondary blast injury, damage resulting from flying debris, and then tertiary, where the victim is thrown, perhaps into an object. Patient assessment of closed and open injuries. It is more difficult to assess a closed injury than to assess an open injury. Anytime you observe bruising, swelling, or deformity, or the patient is reporting pain, the possibility of a closed injury should be considered. An open injury is easier to assess because you can see it. Our patient assessment steps include scene size up, primary assessment, history taking, secondary assessment, and reassessment. With scene size up, remember scene safety. Observe the scenes for hazards to yourself, your crew, and your patient. Assess for the potential of violence. Watch for environmental hazards. Take standard precautions to minimize your direct exposure to body fluids and determine number of patients. You need to consider if you need additional or specialized resources. Mechanism of injury or nature of the illness. You need to look for indicators of the MOI as you assess the scene. This may provide indicators of safety threats, and if the scene is unsafe, request additional resources early. Primary assessment. Focus on identifying and managing life-threatening concerns. Perform a rapid scan of the patient and provide high-flow oxygen if they have closed tissue injuries, as this may help reduce the effects of shock and assist in perfusion of damaged tissue. Do not delay transport of a seriously injured trauma patient to complete non-life-saving treatments in the field. If you discover an open injury with significant bleeding, cover the wound and control the bleeding as quickly as possible. Form a general impression. Important indicators will alert you to the seriousness of the patient's condition. Is the patient awake and interacting with his or her surroundings, or is the patient lying still making no sounds? Does the patient have any apparent life threats? What color is the patient's skin? Is he or she responding to you appropriately or inappropriately? Trauma patients with closed soft tissue injuries may have what appear to be minor injuries. Do not be distracted from looking for more serious hidden injuries, and check for responsiveness using AVPU. Assess airway and breathing. Ensure that the patient has a clear and patent airway. Because trauma was involved, protect the patient from further spinal injury by preventing the head and torso from moving. Assess the patient for adequate breathing. Inspect and palpate the chest wall for decap BTLS. Open, soft tissue injuries of the face and neck have a potential to interfere with the effectiveness of airway and breathing, and you need to evaluate whether your patient's voice and speaking ability is present. Quickly assess the patient's pulse rate and quality. Determine skin condition, color, and temperature. Check cap refill. Your assessment of the pulse and skin will give you an indication as to how aggressively you need to treat your patient for shock. If visible significant bleeding is seen, you must begin the steps necessary to control bleeding. Make your transport decision. Types of patient that need immediate transport include a poor initial general impression, an altered level of consciousness, dyspnea, abnormal vital signs, shock, and severe pain. Patients who have visible significant bleeding or signs of significant internal bleeding may quickly become unstable. Take your history. You need to investigate your chief complaint, obtain a medical history, and be alert for injury-specific signs and symptoms and any pertinent negatives. Obtain a sample history from your patient and use OPQ-RST, as this may provide some background on isolated extremity injuries. Any information you receive will be valuable if the patient becomes unconscious. If the patient is unresponsive, attempt to obtain your history from other sources, such as friends or family members, bystanders, medical alert jewelry, or cards and wallets. Typical signs of an open injury include bleeding, skin breaks, shock, hemorrhage, and disfigurement or loss of a body part. Conditions such as anemia and hemophilia can complicate soft tissue injuries. Secondary assessment. It is more systematic head to toe or focused depending on what's going on with your patient. Perform your physical exam. Look, listen, and feel for signs of airway problems. Ask yourself the following questions. Is my patient sitting in a tripod position? What is my patient's skin color and condition? Are there any signs of increased efforts on respirations, such as retractions, nasal flaring, pursed lip breathing, or use of accessory muscles? Listen for air movement and breath sounds. Assess pulse rate and quality. Determine skin color, temperature, and condition. And check cap refill. Assess the neurologic system, including level of consciousness, pupil size and reactivity, motor response, and sensory response. Assess the musculoskeletal system with a detailed full-body scan. Assess all anatomic regions, looking for the following signs and symptoms: raccoon's eyes, battle signs, and/or drainage of blood or fluid from the ears and nose, jugular vein distension and tracheal deviation. Check the pelvis for stability, check the abdomen, and check the extremities, and record pulse, motor, and sensory function. Vital signs. It is important to reassess the vital signs and identify how quickly the patient's condition is changing. Use appropriate monitoring devices to quantify oxygenation, circulatory status, and blood pressure. Reassess your patient. You need to repeat your primary assessment, reassess your vital signs and the chief complaint, recheck interventions, assess bandaging frequently, and identify and treat changes in condition. Assess and manage all threats to the patient's airway, breathing, and circulation. All patients with closed injuries should receive oxygen via a non-rebreather mask. Expose all wounds, cleanse the wound surface, control bleeding, and be prepared to treat the patient for shock. Extremities that are painful, swollen, or deformed should also be splinted. Describe your mechanism of injury in your communications and documentation, as well as the position in which you found your patient when you arrived on scene. It is important to recognize, estimate, and report blood loss amounts and how rapidly or how much time passed since bleeding started. Include location and description of any soft tissue injuries or other wounds that you have located and treated. Describe the size and depth of the injury and provide an accurate account of how you treated these injuries. Emergency medical care for closed injuries. Small contusions require no special emergency medical care. More extensive closed injuries may involve significant swelling and bleeding beneath the skin, which could lead to hypovolemic shock. Soft tissue injuries may look rather dramatic, and you must still focus on airway and breathing first. If the patient has inadequate breathing, you may have to assist ventilations with a BVM device. Treat a closed soft tissue injury using the RICES mnemonic: rest, ice, compression, elevation, and splinting. You should also be alert for signs of developing shock, which include anxiety or agitation, mental status changes, increasing heart rate, increasing respiratory rate, diaphoresis, cool or clammy skin, and a decreasing blood pressure. If the patient appears to be in shock, you should place them in the shock position, which is supine, by elevating the legs 6 to 12 inches, and provide supplemental high-flow oxygen and rapid transport. Emergency medical care for open injuries. Before you begin to care for a patient with an open wound, you must follow standard precautions. You need to wear gloves, eye protection, and if necessary, a gown and a mask. Make sure that the airway is open and administer high-flow oxygen. Control life-threatening bleeding using direct, even pressure and elevation, pressure dressings or splints, and as the final step, tourniquets. Follow the steps in skill drill 24-1 to control bleeding from an extremity.
All wounds require dressing and bandaging. Dressing and bandaging help control bleeding, protect the wound, and prevent additional contamination and infection. Use appropriate body substance isolation precautions prior to beginning patient care.
How you doing? My name is Brian. I'm an EMT. What happened today?
A check of the distal circulation through capillary refill or pulse check may be performed when appropriate and possible.
Do you hurt anywhere else?
Assessment of motor function and sensation must be performed on all extremities.
Wonderful. Okay. I'm going to check your capillary refill, make sure you got good circulation. Can you wiggle your fingers for me? Wiggle your fingers like this. Does that hurt you at all?
Not really, not too much.
Okay. No other cuts anywhere else. What we're going to do is we're going to bandage you up. We're going to put a pressure dressing on it to control your bleeding so it doesn't bleed anymore. We're going to take it to the hospital. Looks like you're going to get a couple stitches. All right? Okay.
A clean dressing must cover the entire wound. The technique used to apply the dressing must not contaminate the surface of the dressing. Apply pressure sufficient to control hemorrhage without compromising circulation, unless pressure is contraindicated. Adequate bulk must be applied when pressure is contraindicated. Bandages must completely cover all dressing materials and be secure enough to hold both the dressing and bandage firmly in place. The entire process of dressing and bandaging must not cause excessive movement. The bandaging technique must control hemorrhaging without aggravating the injury. A check of the distal circulation through capillary refill or pulse check must be performed when appropriate and possible. Assessment of motor function and sensation must be performed on all extremities. Do not use elastic bandages to secure dressings. The bandage may act like a tourniquet if the injury swells, causing further damage. Proper dressing and bandaging techniques will help ensure a stable wound until further care can be administered if necessary.
All open wounds are assumed to be contaminated and present a risk of infection. By applying a sterile dressing, you are reducing the risk of further contamination. You should not try to remove material from an open wound, no matter how dirty the wound is. Often, you can better control bleeding from open soft tissue wounds by splinting the extremity, even if there is no fracture. Abdominal wounds. An open wound in the abdominal cavity may expose internal organs. In some cases, the organs may even protrude through the wound, an injury we call an evisceration. You must cover the wound with sterile gauze moistened with sterile saline, secure with an occlusive dressing, and keep the organs moist and warm. Most patients with abdominal wounds require immediate transport to a trauma center. Impaled objects. Occasionally, a patient will have an object such as a knife, a fish hook, a wood splinter, or a piece of glass impaled in their body. To treat this, you'll use skill drill 24-2. Only remove an impaled object when the object is in the cheek and obstructs breathing, or the object is in the chest and interferes with CPR. Open neck injuries may be life-threatening. If the veins of the neck are open to the environment, they may suck in air. If enough air is sucked into a blood vessel, it can actually block the flow of blood in the lungs, sending the patient into cardiac arrest. This condition is called an air embolism. To prevent this, cover the wound with an occlusive dressing and apply pressure, but do not compress both carotid arteries at the same time. This can impair circulation to the brain and cause your patient to suffer a stroke. Small animal bites and rabies. A small animal's mouth is heavily contaminated with virulent bacteria. You should consider all small animal bites as contaminated and potentially infected wounds that may require antibiotics, tetanus prophylaxis, and suturing. All small animal bites should be evaluated by a physician. A major concern is the spread of rabies, an acute, potential, fatal viral infection of the central nervous system that can affect all warm-blooded animals. The virus is in the saliva of a rabid or infected animal and is transmitted through biting or licking an open wound. Infection can be prevented only by a series of special vaccine injections. Children, particularly young ones, may be seriously injured or even killed by dogs, and you must assume that the animal may turn and attack you as well. You should not enter the scene until the animal has been secured by the police or an animal control officer. The human mouth contains an exceptionally wide range of virulent bacteria and viruses, more so than even the small animal's mouth. You should regard any human bite that has penetrated the skin as a very serious injury, and this can result in a serious spreading infection. Emergency treatment consists of the following. Apply a dry, sterile dressing. Promptly immobilize the area with a splint or bandage and provide transport to the emergency department for surgical cleansing of the wound and antibiotic therapy. Burns. Burns account for over 10,000 deaths every year, and they are among the most serious and painful of all injuries. A burn occurs when the body or a body part receives more radiant energy than it can absorb, resulting in an injury. Some potential sources of this energy include heat, toxic chemicals, and electricity. Although a burn may be the patient's most obvious injury, you should always perform a complete assessment to determine whether there are serious injuries. Keep in mind that children, elderly patients, and patients with chronic illnesses are more likely to experience shock from burns. The skin serves as a barrier between the environment and the body, and when a person is burned, this barrier has been destroyed. The victim is now at a high risk for infection, hypothermia, hypovolemia, and shock. Burns to the airway are of significant importance because the loose mucosa in the hypopharynx can swell and lead to complete airway obstruction. Circumferential burns of the chest can compromise breathing. Circumferential burns of an extremity can lead to neurovascular compromise and irreversible damage if not appropriately treated. There are 5 factors that will help you determine the severity of a burn, and the first 2 are by far the most important. First of all, you need to determine the depth of the burn, then the extent of the burn. You need to look if there are any critical areas involved, such as the face, the upper airway, the hands, the feet, or the genitalia. Does the patient have any pre-existing medical conditions or other injuries? And is your patient younger than 5 or older than 55? Keep in mind that burns to the face are of particular importance owing to the potential of airway involvement. Burns to the hands or feet or over joints are also considered serious because of the potential for loss of function as the result of scarring. Depth of the burn. There are 3 different depths. Really there are 4, but 3 we're going to talk about here. First is superficial or first-degree burns. They involve only the top layer of the skin, the epidermis. The skin turns red but does not blister or actually burn through, and it is painful. A good example of this is a sunburn. Next are partial thickness or second-degree burns. These involve the epidermis and some portion of the dermis. These burns do not destroy the entire thickness of the skin, nor is the subcutaneous tissue injured. Typically, the skin is moist, mottled, and white to red. There are blisters present, and it can cause intense pain. Last is full thickness or third-degree burns. These extend through all skin layers and may involve subcutaneous layers, muscle, bone, or internal organs. Sometimes we refer to the ones with bone and internal organs as fourth-degree burns. If the nerve endings have been destroyed, a severely burned area may have no feeling. However, the surrounding and less severely burned areas may be extremely painful. Significant airway burns are also serious, as they may be associated with singed hair within the nostrils, soot around the nose and mouth, hoarseness, and hypoxia. We have some great examples here of superficial, partial thickness, and full thickness burns. In the top is skin demographics or skin schematics, and in the bottom are actual burns. Extent of the burn. The extent of a burn can be estimated using the rule of 9s, which divides the body into sections, each representing approximately 9% of the total body surface area. The proportions differ for infants, children, and adults, and this is something you must know for your registry exam. It is very important in burn treatment that we properly identify percentage of burned areas. If you learn these pictures, then you will really understand this. And when we talk about the torso being 18% on the front, it's also 18% on the back. So if a burn is only of the chest, it's 9%, and of the abdomen, it's 9%, making up the 18%. Pay particular attention when you read questions as to how these are divided out. Chemical burns can occur whenever a toxic substance contacts the body. Most chemical burns are caused by strong acids or strong alkalis. The eyes are particularly vulnerable. The severity of the chemical burn is directly related to the type of chemical, the concentration, and the duration of exposure. And we must wear appropriate chemical-resistant gloves and eye protection whenever we care for patients who experience chemical burns. Treatment can be specific to the chemical agent. To manage these types of burns, we want to, number one, stop the burning process and remove any chemical. If the chemical is dry powder, we brush it off the skin and clothing before we flush it with water. There are some dry chemicals that react violently with water. You want to remove the patient's clothing, including shoes, stockings, gloves, and any jewelry or glasses. If there are liquid chemicals involved, immediately begin to flush the burned area with large amounts of water. Continue flooding the area with gallons of water for 15 to 20 minutes after the patient says the burning pain has stopped. If the patient has gotten chemicals into their eye, hold the eyelid open while flooding the eye with a gentle stream of water. Electrical burns. These may be the result of contact with high or low voltage electricity. High voltage burns may occur, for example, when utility workers make direct contact with power lines. Ordinary household current can cause severe burns and cardiac arrhythmias. For electricity to flow, there must be a complete circuit between the electrical source and the ground. Any substance that prevents this circuit from being completed is called an insulator. Any substance that allows a current to flow through is called a conductor. The human body is a good conductor. Thus, electrical burns occur when the body or a part of it completes a circuit connecting a power source to the ground. The type of electric current, magnitude of current, and voltage have the effects of the seriousness of the burn. Your safety is of particular importance when you are called to the scene of an emergency involving electricity. You can be fatally injured by coming into contact with power lines. You also can be fatally injured by touching a patient who is still in contact with a live power line or with any other electrical source. You must never attempt to remove someone from an electrical source unless you are specifically trained to do so. Always assume that any down power line is live until the power company tells you it's not. A burn injury appears where the electricity enters and exits the body. There are two dangers specifically associated with electrical burns. There may be a large amount of deep tissue injury, and the patient may go into cardiac or respiratory arrest from the electric shock. Electrical burn management. Electrical current can cross the chest and cause cardiac arrest or arrhythmias. If indicated, begin CPR on the patient and apply the AED. You should be prepared to defibrillate if necessary. Give supplemental oxygen and monitor the patient closely for respiratory and cardiac arrest. Treat the soft tissue injuries by applying dry sterile dressing on all burn wounds and splinting suspected fractures. Provide prompt transport. Thermal burns are caused by heat. Most commonly, these are caused by scalds or an open flame. A flame burn is very often a deep burn, especially if a person's clothing catches fire. A scald burn is most commonly seen in children and handicapped adults, but can happen to anyone, particularly while cooking. Hot liquids produce scald injuries, and scald burns often cover large surface areas of the body because they spread very quickly. Coming in contact with hot objects produces a contact burn. Contact burns are rarely deep unless the patient was prevented from drawing away from the hot object. A steam burn can produce a topical scald burn, and minor steam burns are common when microwaving food covered with plastic wrap. A flash burn is produced by an explosion which may briefly expose a person to very intense heat. Lightning strikes can also cause flash burns. Management of thermal burns. The first step is to stop the burning source, cool the burned area if appropriate, and remove jewelry. Maintain a high index of suspicion for inhalation injuries. Increased exposure time also increases damage to the patient. The larger the burn, the more likely the patient will be susceptible to hypothermia and/or hypovolemia. All patients with large surface burns should have a dry dressing applied to help maintain body temperature, prevent infection, and provide comfort. Inhalation burns can occur when burning takes place in enclosed spaces without ventilation. When the upper airway is exposed to excessive heat, the patient can experience rapid and serious airway compromise. Upper airway damage is often associated with the inhalation of superheated gases, and lower airway damage is more often associated with the inhalation of chemicals and particulate matter. When treating a patient for inhalation injuries, you may encounter severe upper airway swelling, requiring intervention immediately after a severe burn. Consider requesting ALS assistance if the patient has signs and symptoms of edema. The combustion process produces a variety of toxic gases, and the less efficient the combustion process, the more toxic the gases may be. Carbon monoxide intoxication should be considered whenever a group of people in the same place all report headache or nausea. Generally, these will be flu-like symptoms. Management of inhaled burns. First, ensure your own safety and the safety of your coworkers. Pre-hospital treatment of a patient with suspected hydrogen cyanide poisoning includes decontamination and supportive care. And care for any toxic gas exposure includes recognition, identification, and supportive treatment. Radiation. Acute radiation exposure has become more than a theoretical issue because of the use of radioactive materials having increased in industry and medicine. Since 1944, there have been more than 400 radiation accidents involving significant radiation exposure to more than 3,000 people. Potential threats include incidents related to the use and transportation of radioactive isotopes and intentionally released radioactivity in terrorist attacks. You must determine if there has been a radiation exposure and then attempt to determine whether ongoing exposure continues to exist. There are 3 types of ionizing radiation: alpha, beta, and gamma. Alpha particles have little penetrating energy and are easily stopped by the skin. Beta particles have greater penetrating power and can travel much further in air than alpha, and they can penetrate the skin but can be blocked by simple protective clothing designed for this purpose. And gamma, which is the threat is directly proportional to its wavelength, and this type of radiation is very penetrating and easily passes through the body and solid materials. Most ionizing radiation accidents involve gamma radiation or X-rays. Radiation burns require special rescue techniques beyond the initial training of an EMT. You need to maintain a safe distance and wait for the hazmat team to decontaminate the victim before initiating patient care. When patients have a radioactive source on their body, they are contaminated and must be initially cared for by hazmat. Most contaminants can be removed by simply removing clothing. We need to irrigate open wounds and notify the emergency department and identify the radioactive source and the length of exposure. Limit your duration of exposure, increase your distance from the source, and attempt to place shielding between yourself and sources of gamma radiation. Burn assessment. When you are assessing a burn, it is important that you classify it by source, depth, and severity. We always follow our steps of scene size up, primary assessment, history taking, secondary assessment, and reassessment. Scene safety. We need to observe the scene for hazards and threats to the safety of you and your crew, bystanders, and your patient. Ensure that the factors that led to the patient's burn injury do not pose a hazard for you and your crew. Evaluate the mechanism or nature. Attempt to determine the type of burn that has been sustained and the mechanism. Assess the scene for environmental hazards, determine your number of patients, and call for additional resources early. Consider the potential for spinal injuries, inhalation, and other types of injuries. Primary assessment begins with a rapid scan and form a general impression. Look for clues to help identify how serious the injuries are and how quickly you need to assess and treat them. Be suspicious of clues that may indicate abuse. Always consider the need for manual spinal stabilization and check for responsiveness utilizing the AVPU scale. In all patients who have a level of consciousness that's less than alert and oriented, administer high-flow oxygen via a non-rebreather and immediately transport. Airway and breathing. Ensure that the patient has a clear and patent airway, and be alert to signs that the patient has inhaled hot gases or vapors, such as singed facial hair and soot present in or around the airway. Copious secretions and frequent coughing may indicate respiratory burns, and you need to quickly assess for adequate breathing and inspect and palpate the chest wall for decap BTLS. Quickly assess pulse rate and quality, determine perfusion based on the patient's skin condition, color, temperature, and cap refill time, and take the necessary steps to control significant bleeding. Also assess for shock. Make your transport decision. Consider quickly transporting a patient who has an airway or breathing problem, significant burn injuries, significant external bleeding, significant signs and symptoms of internal bleeding. It may be appropriate for you to rendezvous with ALS providers. Take your history. Investigate your chief complaint and be alert for signs or symptoms of other injuries due to the mechanism. Get a medical history and be alert for injury-specific signs and symptoms and pertinent negatives. Some typical signs of a burn are pain, redness, swelling, blisters, and charring. Typically, the symptoms include pain or burning at the injury site. Regardless of the type of burn, it is very important for you to stop the burning process, apply dressing to prevent contamination, and treat for shock. Obtain a sample history. Along with a sample history, be sure to ask the following questions. Are you having any difficulty breathing? Are you having any difficulty swallowing? Or are you having any pain? Check whether the patient has an emergency medical identification device. Secondary assessment. Perform a full body scan. Assess the patient from head to toe, evaluating for DCAP BTLS. Make a rough estimate using the rule of nines of the extent of the burned area. Determine what classification of burns the victim has sustained and determine the severity. Package your patient for transport based on your findings. Assess the respiratory system. This involves look, listen, and feel. Look for soot around the mouth, soot around the nose, or singed nasal or facial hairs. Listen to breath sounds with a stethoscope. Assess pulse rate and quality. Determine skin condition, color, and temperature, and check cap refill. Assess the patient's neurologic system, including level of consciousness, pupil size and reactivity, motor response, and sensory response. Assess the musculoskeletal system, looking for raccoon's eyes, battle signs, and or drainage of blood or fluid from the ears or nose. Look for JVD and tracheal deviation. Check pelvis for stability. Check the abdomen. Check the extremities and umbilical cord, pulse, motor, and sensory function. Check vital signs. Determining an early set of vital signs will help you know how your patient is tolerating their injuries. Blood pressure, pulse, and skin assessment for perfusion are important. Use your monitoring devices for oxygenation, circulatory status, and blood pressure. Reassess. Repeat the primary assessment and reassess the vital signs. Reassess the chief complaint. Reevaluate interventions and treatment, such as stopping the burning process, assess and treat breathing, and support circulation. Provide rapid transport. Oxygen is mandatory for inhalation burns, but is also helpful in patients with smaller burns. If the patient has signs of hypoperfusion, treat aggressively for shock and provide rapid transport. Provide hospital personnel with the description of how the burn occurred. Include the extent of the burn, including the amount of body surface area, the depth, and location, and if special areas are involved, they should be specifically mentioned and documented. Emergency medical care. Your first responsibility in caring for a patient with a burn is to stop the burning process and prevent additional injury. When caring for a patient with burns, follow the steps in Skill Drill 24-3. All wounds require bandaging. Sometimes splints can help control bleeding and provide firm support for dressing. Many different types of dressings and bandages exist. Dressings and bandages have three functions, and these are to control bleeding, to protect the wound from further damage, and to prevent further contamination and infection. Most wounds may be covered by sterile dressings, and these are universal. Generally, conventional 4x4 and 4x8 gauze are used. Assorted small adhesive-type dressings and soft self-adherent roller dressings are also used. The universal dressing is ideal for covering large open wounds. Gauze pads are appropriate for smaller wounds. Adhesive-type dressings are useful for minor wounds. Occlusive dressings prevent air and liquid from entering or exiting the wound. They're made of Vaseline gauze, aluminum foil, or plastic. They are used to cover sucking chest wounds, abdominal eviscerations, and neck injuries. To keep dressings in place during transport, you can use bandages. These are soft roller bandages, rolls of gauze, triangular bandages, and adhesive tape. The self-adherent soft roller bandages are the easiest to use. Adhesive tape holds small dressings in place and helps secure larger dressings. Some people, however, are allergic to adhesive tape and use paper or plastic tape. Do not use elastic bandages to secure dressings, because if the injury swells, the bandage may become a tourniquet and cause further tissue damage. You should always check the limb distal to the bandage for signs of impaired circulation and loss of sensation. Splints are useful in stabilizing broken extremities, and they can be used with dressings to help control bleeding from soft tissue injuries. If a wound continues to bleed despite the use of direct pressure, quickly proceed to the use of a tourniquet. In summary, the skin protects the body by keeping pathogens out, water in, and assisting in regulation of body temperature. There are 3 types of soft tissue injuries: closed, open, and burns. Closed soft tissue injuries are characterized by a history of blunt trauma, pain at the site of the injury, swelling beneath the skin, and discoloration. Contusions, hematomas, and crush injuries are classified as closed. Treating a closed soft tissue injury by applying the mnemonic RICEs: rest, ice, compression, elevation, and splinting. Open injuries differ from closed injuries in that the protective layer of skin is damaged. Abrasions, lacerations, avulsions, and penetrating wounds are classified as open injuries. Treat an open soft tissue injury by applying direct pressure with a sterile bandage, using a roller bandage, and splint. The assessment of an open injury is generally easier than the assessment of a closed injury because you can actually see the injury. Burns are serious and painful soft tissue injuries caused by heat or thermal, chemicals, electricity, or radiation. Burns are classified primarily by depth and extent of burn injury and the body area involved. Burns are considered to be superficial, partial thickness, or full thickness based on depth. When providing emergency care, use standard precautions: cool the burned area to prevent further damage, and remove jewelry and constrictive clothing. When providing emergency care for burns, ensure an open airway exists and that it's clear. Provide high-flow oxygen, be alert to signs and symptoms of inhalation injury, and place sterile dressings over the burned area. Cover the patient with a blanket and provide prompt transport. Small animal and human bites can lead to serious infection and must be evaluated by a physician. Small animals can carry rabies. Dressings and bandages are designed to control bleeding, protect the wound from further damage, and prevent further contamination, as well as prevention of infection. Thanks for your attention, and as I said, always bring questions regarding this lecture to your face-to-face class with your instructor.